بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. We will start the lectures for anesthesia for congenital heart disease. They will be divided over 6 lectures. Each lecture may be divided into several parts according to their length. Today we'll start with left to right shunt lesions. We'll talk about the general considerations for left to right shunt lesions. Left to right shunt lesions, generally we can the following pathologies can be considered left to right shunt lesions, like atrial septal defect, ventricular septal defect, anomalous pulmonary venous drainage, whether partial or total, atrioventricular canal, AV canal, DORV, double outlet right ventricle, truncus arteriosus, and AP window. These we will discuss in this lecture. General considerations for left to right shunt lesions. In the preoperative assessment, we'll look at the age and weight of the patient, because the patient may be cachectic. Baseline saturation. Usually the lung is there is overflow on the lung. The lung is congested, so the saturation is usually 100, unless there is severe congestion leading to pulmonary edema and impairment of ventilation, or the patient has progressed to pulmonary hypertension. History of congestion, recurrent chest infections, pulmonary edema, symptoms of sympathetic stimulation in compensated heart failure, presented with sweating, tachycardia, and tachypnea. Tachypnea impairs feeding and impairs growth more. And assessment of the right side function, pulmonary pressures, tricuspid regurg, hepatomegaly. And in these patients, systemic congestion presents as hepatomegaly, not low limb edema, unless the child is old and is walking. But infants who are not walking may not present with low limb edema. Assessment of other defects or congenital heart diseases. This is important because when we are addressing a certain congenital heart disease like VSD or a canal or whatever, we should not miss other congenital heart diseases like PFO. Risk of arrhythmias with high QPQS, atrial dilatation occurs, so there is a higher risk of atrial arrhythmias. History of paradoxical emboli that may cause transient ischemic attacks and stroke, pulmonary hypertension, and up to irreversible pulmonary hypertension with right to left shunt lesions, that is called Eisenmenger syndrome. Degree of shunting depends on the size of the defect. So the larger the defect, the more the shunt. The relative difference between the LV and RV diastolic pressures in shunts that are before the AV valves, like the ASD and partial anomalies. So in these conditions, the shunt depends on the diastolic pressures of the left and right ventricles during diastole. But lesions or shunts distal to the AV valves, like the VSD or the PDA, the relative difference between the systemic vascular resistance and the pulmonary vascular resistance determine the degree of shunting. The blood viscosity, hematocrit, the less the viscosity, the more the shunt. So if the blood is more liquid, it moves easily through the shunt. We should consider that in the first 3 months there is physiological decline in the pulmonary vascular resistance and the hematocrit level, causing excess separation of the symptoms. So a newborn may may not present with severe left to right shunting during the first 2 or 3 months, but then the symptoms appear or exacerbate afterwards. Now, when considering the dilatation of the chambers in ASDs, we find that the right side dilates before the left side, dilates first, because during diastole and also systole there is left to right shunting, so there is a volume overload on the right atrium and then the right ventricle, so the right side dilates and there is overflow on the lung, so the left atrium receives more blood than usual, so the left side dilates. In VSDs, the left side dilates first because during systole, blood flows from the left ventricle to the pulmonary artery directly, so there is overflow and then more blood than normal comes to the left atrium, so the left atrium and the left ventricle receive more blood than usual. So the left side dilates more, and the same with PDA. So we should mind this difference, that in conditions in shunts that are before the AV valves, usually the right side dilates first, and the shunts that are distal to the AV valves, the left side dilates first. Signs of pulmonary hypertension development. The patient stops having recurrent chest infections, apparent improvement, clear chest X-ray. So we find this in patients. The mother, in history, she says that the child used to have recurrent chest infections, recurrent hospital admissions, and even ICU admissions, and then she says happily that in the last 3 or 4 months he improved, he got better with less symptoms. Unfortunately, this history is a bad history. It is ominous. It shows that the patient developed pulmonary hypertension. The chest X-ray becomes clear with no congestion. Cyanosis with straining. Even if the patient apparently gets better, but with crying he may get bluer. So cyanosis with the straining or crying. Hemoptysis in developed in late or severe pulmonary hypertension, congested tender liver, elevated liver enzymes, and then anasarca and cyanosis with Eisenmenger syndrome. Intraoperative, we keep hemodynamic goals, maintain adequate preload without overloading to avoid congestion, maintain normal rate and rhythm. Contractility, maintain adequate contractility. Low systemic vascular resistance, encourage forward flow, and high pulmonary vascular resistance to decrease the shunting. We would not induce aggressively pulmonary hypertension, but we decrease FI2 without cyanosis, without decreasing the saturation. High normal PCO2, permissive hypercapnia, but we do not induce hypercapnia. We do not allow the patient to the PCO2 to be above 50, but we allow the PCO2 to drift towards hypercapnia. We put PEEP in the ventilator, avoid alkalosis. If we are aggressive, the shunt may reverse. Avoid the congestion, so decrease fluids, and these patients are usually on diuretics. Before and after induction and during the operation, monitor signs of lung congestion and pulmonary edema. So when the patient enters the operating room, I listen to the bases with the stethoscope, and then after induction I listen to the bases before the skin incision, or before sterilizing the surgical the chest. I listen to the bases, and at the end of the operation, fine basal crepitations, hypoxia and hypercapnia, increased airway pressures, pink frothy sputum from the endotracheal tube if it is severe pulmonary congestion or pulmonary edema. Cerebral oximetry may be used in congestive heart failure, de-airing the lines to decrease the risk of pulmonary paradoxical air emboli or pulmonary air emboli. Antibiotics. If the patient develops pulmonary hypertension, the management is the opposite. I increase FiO2, I decrease PCO2, also not reaching respiratory alkalosis, but to the limit of permissive hypocapnia. Increase the pH is more effective using bicarb. Good analgesia and anesthesia. Avoid hypoglycemia, avoid hypothermia. So this is to avoid the sympathetic stimulation and stress. Inodilators, pulmonary vasodilators like sildenafil, magnesium sulfate, and nitric oxide. To talk about ASD, atrial septal defect, the types are, this view we are looking at the interatrial septum from the right side, from the right atrial side. So the ASD primum is related to the tricuspid valve, with no tissue between it and the tricuspid valve. The ASD secundum with rims all around it. Sinus venosus related to the superior vena cava or the inferior vena cava, the PFO, and the coronary sinus defect. This is the coronary sinus, this is not the ASD, but the defect is a deroofing of the coronary sinus when it passes behind the heart in the AV groove, the atrioventricular groove. It passes below the left atrium. So if the roof of the sinus, of the coronary sinus, is absent and there is a connection between it and the left atrium, so there will be shunting from the left atrium to the coronary sinus, and then drain this blood from the left atrium. It drains from the orifice of the coronary sinus into the right atrium. So this is effectively an ASD. To talk about the embryology just a little, to understand the differences between these types. The ostium secundum in the embryo, the two atria are one chamber, the sinus venosus, or they are one chamber, and they get divided by the ostium secundum. The septum prime, it develops from the roof of the common chamber, and then it merges with the primordial body, the endocardial cushion, this one in blue. So they fuse together. If the endocardial cushion is absent, is congenitally absent, so the septum primum will not join anything in the middle. So an ostium primum is left, is formed. So this is an ASD primum, and this is almost always comes with an AV canal, whether partial or complete AV canal, because an absence of endocardial cushion not only prevents the closure of this ostium primum, but it also prevents the separation of the mitral and tricuspid valves and the development of the membranous interventricular septum. So the lack of the endocardial cushion gives rise to this ostium primum that is part of an AV canal. We'll come to this later in the part of the AV canal of this lecture. Then the septum secundum develops also from the roof. This septum secundum it comes down and then closes the septum, and it fuses with the septum primum. At the same time, the septum primum at the middle, holes are formed inside in the septum primum. These holes, if left, if they get larger, very larger than the part of the septum secundum that is left, it forms an ASD secundum. So usually when the septum secundum is formed, a defect is left inside it, and then the holes that are created in the septum primum, those two holes are usually not at the same level. So a form of a valve is created, allowing the blood to flow from the right atrium to the right ventricle, and this is the PFO, patent foramen ovale. So if the hole inside the septum secundum, the septum primum, is large enough to cover also the foramen ovale, so this becomes the ASD secundum. And also if after birth, when the pressure in the left atrium rises because of the blood flow to the lung, so this valve closes, and the ostium and the PFO should close, and then they fuse together, and the PFO is closed. But if they do not fuse together, so we are left with a PFO. Now, we're talking of the preoperative assessment, the same like the general considerations that we talked about previously. Then we assess the number, size, and direction of blood flow in the ASDs, the type of the ASD and the rims, whether the rims are deficient or not, because this decides whether the ASD can be closed by a device, by a transcatheter device, or they need surgery. ASDs cause left to right shunt during diastole with volume overload on the right side. We said this before. Assessment of other defects or congenital heart diseases. This may be especially important because in sinus venosus ASD, usually there is partial or total anomalous pulmonary venous drainage. If there is total anomalous pulmonary venous drainage, so I will find that the shunting through the ASD is right to left, and if this ASD is closed by a device or surgically without noticing that it is a total anomalous, the patient may arrest on table, because there is the patient is dependent on the ASD for the perfusion of the left side of the heart. We see whether there is a left SVC, because in coronary sinus ASD there is usually a left SVC, and if there is a primum ASD, so I expect that the patient is a canal, whether partial or complete. So I look at the mitral valve or the left AV valve to see whether there is a cleft and a regurg in the mitral. It is very important to diagnose whether the patient is ASD dependent, like in cases of total anomalous pulmonary venous drainage, like in tricuspid atresia and in TGA. And in these cases, ASD closure is fatal. And as I said, in these cases, the total anomalous and the tricuspid atresia, the flow across the ASD is right to left. So this is a mistake that shouldn't happen, but should be mentioned. So this is again, in an ASD, there is volume overload on the right side, or the right side dilates, and the pulmonary arteries dilate, and the pulmonary veins dilate. This is an ASD. This is a PFO showing right to left shunt. In this view, we reduced the requisite limit of the color flow duplex to see the PFO better. Because sometimes this is a big PFO, but sometimes it is smaller, so we need to do this trick to see it better. This is a PFO with a normal requisite limit. This is an ASD secundum with rims. You can see now the AV valve rim and the pulmonary veins rim. We should mention that about the rims, especially for the ASD secundum that can be closed by a device. This is the AV valve rim, and this is the pulmonary veins rim. This is the SVC rim and the IVC rim, and this is the aortic rim related to the aortic valve. In the 4-chamber view, we can see the AV valve rim and the pulmonary veins rim. In the aortic valve, in the short axis, we can see the aortic valve rim and the posterior rim. And in the bicaval view, we can see the SVC rim and the IVC rim. So in this view, this is this is a PFO, but if this is an ASD secundum, so this is the SVC rim and this is the IVC rim. And in this 4-chamber, this is the AV valve rim and this is the pulmonary veins rim. This is the inflow of the pulmonary vein. The red color is the the right upper pulmonary vein. So this is the AV valve rim. Surgically, it is directly closed or with a patch closure. In cases of sinus venosus ASD, it is closed by a baffle or by a baffle plus an SVC translocation to the right atrial appendage. This is called the Warden operation. The point is, if the anomalous pulmonary vein is connected to the SVC, so I cannot dislocate the anomalous pulmonary vein because the pulmonary veins are posterior and fixed coming out of the lung, so they are less mobile than the superior vena cava itself. So it is easier to transport the superior vena cava to the right atrium than to transport the anomalous pulmonary vein to the left atrium. So what is done in the Warden's operation is that we transport the superior vena cava to the right atrium, right atrial appendage, and then this remaining part of the superior vena cava is baffled through with a patch through the ASD to the left atrium. So this is what is done. So blood flows from the anomalous pulmonary vein to the stump of the superior vena cava, then through the ASD to the left atrium, and with the baffle we isolate this part from the left of the right atrium. This is called the Warden's operation. Post-operative, the TE view, intraoperative, the TE views, we see the site of the ASD, the size of the ASD, the number of the ASDs, more than one may be found. Other defects like anomalous pulmonary venous drainage, we look at the RV function and filling, and of course we do a full study, because any other defects or congenital anomalies may be found. So we in any case, in any congenital heart case or any case in general, whenever we put the TE, we should make a full study. Post-operatively, we transfer to the ICU, intubated and ventilated after surgical closure. But on-table extubation may be considered. Careful loading after ASD closure. This is very important because the LV is not used to the increased preload and may fail. So inotropes may be considered, especially with dilated right side and pulmonary hypertension. This careful loading is important because generally ASD cases are considered mild cases or easy cases in older children, so they can be taken lightly. So we should not take these cases lightly, especially considering loading. So we should not load this patient unnecessarily. Because what happens is that in these cases the LV may take volume, and then suddenly may fail, and this sometimes occurs post-operative in the ICU. So after transporting the patient may take some blood unattended, so suddenly the patient may fail. Post-operative TE, residual defects across the ASD or the patch, other ASDs, biventricular function, estimated RVSP, RV right ventricular systolic pressure, gradient across the vena cava and the pulmonary veins, because the closure of the ASD, especially in sinus venosus ASD, may impair the drainage or narrow the orifices of these veins. So I should check the gradient across, the mean gradient across. Follow the IVC to make sure it opens into the right atrium. This is a mistake that should not happen, but it may happen. That especially in large ASDs with small or deficient IVC rims, the surgeon may not detect, may not differentiate between the Eustachian valve and the IVC rim. So putting the patch, he may close the ESD or the SVC rim to the Eustachian valve and not to the IVC rim. So this may cause the inferior vena cava to drain into the into the left atrium, and the patient comes off bypass cyanosed because the venous drainage of the lower limb goes to the right side, to the left side, sorry. So this is a right to left shunting. So we should follow the ESD, should follow the IVC flow into the right atrium. Like for example here, this is the Eustachian valve. So if the defect is large, the surgeon may close the patch. Instead of closing the patch like this, he may close the patch from the Eustachian valve to the SVC rim. So the flow of the IVC goes towards the left atrium instead of the right atrium. This is after closure, so I make sure that the IVC flows into the right atrium and not the left atrium. In cath lab, the ASD may be closed by a device, and as we see, the device closes and is attached to the rims. So if a rim is deficient, the device may not be stable and may embolize. Indicated in large enough children for the introducer sheath size, a type of ASD, secondum or PFO, adequate rims. In the cath lab, sedation if no TE is required. We may use dexmedetomidine, loading 0.5 to 1 mic per kg, and then infusion with top-ups of midazolam, propofol, or ketamine increments as needed. Nasal oxygen mask or laryngeal mask airway. General anesthesia if TE is required. Heparin 100 international units per kg. Transfers to ICU, usually extubated after device closure. Careful, and the extubation as much as possible should be smooth with no much straining or coughing to avoid the device embolization. Careful loading after ESD closure. Hemodynamic stability, smooth extubation, avoid straining and crying to avoid embolization of the device. Complications: air embolism, arrhythmias, especially heart block. The device may if the device encroaches or puts pressure on the AV node, heart block may occur. Thrombus formation on the device or applicator, that's why we use heparin. Device may impair the mitral valve or tricuspid valve function. If the device is large enough and encroaches upon the mitral or tricuspid valve, it may impair the movement of the cusps. Embolization of the device, pericardial hemorrhage or tamponade. So we should check with the transthoracic echo after the procedure to check for hemorrhage. And that's it for this part of the lecture.